Hello, and welcome to Radiology for Acute Care Nurse Practitioners. My name is Ruth Ann Skinner. I'm an acute care nurse practitioner at Grand Canyon University. Students often ask me for more information regarding radiology. However, please remember radiologists have gone to 4 more years after medical school. You are not expected to know everything. Today we are going to go over radiology basics and discuss the information most important to nurse practitioners, how to verify lines, look at plain films, and identify emergencies. When the first x-ray was taken in the early 19th century, I do not believe they would realize how useful of a tool it would be for diagnosis and treatment of diseases. Radiology images are nice for confirmation, but do not let it replace a good HPI and physical assessment. There are several ways in which radiology images are produced. Conventional radiology includes mammography and fluoroscopy, which is the live image. We will discuss each of these modalities. Conventional radiology, often referred to as x-rays, are very helpful in a quick look of the patient. Density is a measurement or the degree of darkening. Technically, it is called transmitted density since it is a measure of light transmitted through the film. Opacity refers to the transparency of the image. X-rays are great at looking at metal, bone, soft tissue, and even gas. Attenuation refers to the strength of the signal. Density is the dark regions. The enhancement is the light areas, which demonstrate bone here and even cancer when it lights up. Unfortunately, CTs use a lot of radiation. Many EMRs have implemented clinical support decision tools that will prompt the provider when the patient has had too many CTs. In patients that have had serial CTs of the head, this is unavoidable, and the alert will need to be overridden. Nuclear medicine uses small amounts of radioactive material to diagnose and treat. The patient will be radioactive until the radiation therapy is cleared for the patient, so patients should be cognizant when near children or pregnant women. Ultrasound imaging or sonography uses high-frequency sounds to view inside the body. Because ultrasound images are captured in real time, they can also show movement of the body's internal organs as well as blood flowing through the blood vessels. Unlike X-ray imaging, there is no ionized radiation exposure associated with ultrasound imaging. As many of us have seen in the ICU, ultrasounds can be portable and used in acute situations when looking at heart flow. T1 and T2 are different types of images based upon pulse sequences on an MRI. I use the T1 images when looking at a CT of the head. STIR images are another type of images produced. If you're worried about inflammation, STIR images can pick it up relatively easy. You have to be very careful that the patient does not have any electrical implants, such as pacemakers or spinal cord stimulators. This is practice of looking at the different type of modalities. Do an honest guess here. Starting clockwise, we have the fluoro, CT, ultrasound, and MRI. When looking at images, you need to go back and remember the 5 rights. Is this patient right? Is this study right? Are the images technically adequate? As an ordering provider, you must look at your images, verify emergencies, and check your lines. Additionally, always follow up with the radiology experts in the final report. The first thing when verifying technically adequate images is confirming the penetration. You do not want to have too much light or darkness as it can give false diagnoses. Confirm the rotation. Here, confirm the clavicles and the clavicular heads are in line. The second image is grossly rotated and noted when you look at the clavicles. Here is a closer image to view the clavicle heads. Additionally, note how important the rotation is because here it almost looks like the patient has a pneumothorax due to the skin folds. When looking at the anatomy of a chest x-ray, confirm that all lung fields are showing. Ensure that both complete costophrenic angles are present. If the edges have blunting, it can indicate pleural effusion or fibrosis. Do not exclude these diagnoses by not having a complete image. Chest tube insertion helps drain air, blood, or fluid from the pleural space, which is the space surrounding the lungs. It is inserted through the chest wall into the pleural. Look for the light line exiting the body. The pleural effusion seen is indicated in an indication for a chest tube. In fact, on the right side, you can see the fluid level line. A common concern for acute care nurse practitioners is the common question, can I use my line? This is a great breakdown of where you should see your central lines. When in doubt, wait for the radiologist. Remember that when you are working clinically, you will become an expert in your service line, so don't feel overwhelmed right now. Track the catheter from the left IJ to the ACGA. Here is the anatomy of the vessels to visualize the vessels as well. Can you find the approach? Entering from the right IJ and terminating in the SVC. Try to find the SVC here. Another common question nurse practitioners receive from bedside nurses is, can I use my duotube? This shows the tip of the gastric tube is easily seen in the fundus of the stomach. This position is appropriate for meds or suction if needed. If the patient will be receiving tube feedings, the duotube is used and should be in the duodenum to decrease aspiration. For this image, it would need to be inserted a little further and your hook will be able to be seen. This is a great image showing the proper placement of the different types of gastric tubes. Again, notice the hook. This is a common scene when working in the ICU. Morning chest x-rays will help confirm placement of your tubes and lines which may have moved through daily ICU practices, such as baths and turning. The chest tubes are seen as discussed. The ET tube should be right above the carina. The NG tube will be in the left upper quadrant, and the PA catheter with the appropriate right-sided location loop. The pulmonary artery catheter Swan scans allows direct simultaneous measurement of pressures in the right atrium, right ventricle, pulmonary artery, and the filling pressure or wedge pressure of the left atrium. Due to controversy of risk versus benefit, though, the use of PA catheters has definitely decreased. A research article indicated that chest x-rays successfully changed the plan of care in 60% of patients, decreasing unneeded referrals and increasing patient assurance. Chest x-rays are a great, simple diagnostic tool for a quick look at malignancies, pneumonia, COPD, or CHF. Look at the image at the opacity abnormalities. Common differentials are included. This is a pulmonary mass, which is an area of pulmonary opacities that measure more than 30 millimeters. The common cause for a pulmonary mass is lung cancer. We see the hyperdensity region on the left side again. The term pulmonary infiltrate is considered a nonspecific and imprecise descriptive word. The term infiltrate refers to an abnormal substance that accumulates gradually within cells or body tissues. So this could be fluid, infection, or other things. What is an infiltrate? As you notice, this is a very clear fissure line on the lobes. This is a classic right middle lobe infiltrate from aspiration pneumonia. Knowing the specifics allows us to choose a better antibiotic. This can be difficult imaging if you cannot rule out overexposure due to the generalized haze. However, this is a very specific sign for pulmonary edema. The bat wing sign is not always seen, but can indicate pulmonary edema from CHF. The abdominal x-ray can help diagnose some abdominal conditions, such as small and large bowel obstructions. Renal and urethral and bladder stones can sometimes be identified on plain x-ray, although it is now usual to use a CT as a first-line investigation to confirm suspicion. Gallstones are sometimes noted on the x-ray, although ultrasound is much more usual imaging modality when clinically suspected. The KUB stands for kidney, uterus, and bladder, but it can do so much more since it is a quick and easy look. If a patient presents with clinical features of obstruction, then radiologic assessment can be very useful in help determining the level of obstruction. Any part of the bowel may be visual if it contains gas or air within the lumen. gas and air of the low density and forms a natural contrast against surrounding denser tissues. The upper limit of normal diameter of the bowel is generally accepted as 3 centimeters for the small bowel, 6 centimeters for the colon, and 9 centimeters for the cecum, which is the 3-6-9 rule. This is a 56-year-old male with no significant past medical history who presents to the ER with a 3-day course of abdominal pain and now with bilious vomiting. Using our 3-6-9 rule, we can see this patient has a large bowel obstruction. But now what? Is diagnosis complete? A CT was obtained which showed enhancement. The biopsy indicated colon cancer, which was the final diagnosis caused because of the large bowel obstruction. Large bowel obstructions can occur because of many different causes. When diagnosing, use the symptoms as your guide. This patient presented to the ER appearing very septic looking and with x-rays was diagnosed with toxic megacolon. Bone abnormalities are often seen on the KUB as incidental findings. Can you identify the lines on this popular image? This is a 23-year-old female with no significant past medical history who was complaining of abdominal pain and difficulty voiding. Surprise, you're pregnant.